la diapositiva. Grazie.
Presento Suzanne Freitag in inglese perché lo merita, così crediamo tutto. We have the honor of having with us this afternoon Suzanne Freitag. She's one of a kind, really, because she's a global leader and educator in oculoplastic and orbital surgery. Now her position is the director of the autoimmune surgery service and co-director of the Center for Thyroid Eye Disease and Orbital Surgery at Massachusetts IMD. She's a member of the Harvard Medical School faculty. Her main fields of interest are the Graves' orbitopathy, orbital and lacrimal surgery, cosmetic eyelid surgery, eyelid tumors, and socket surgery. Her CV is impressive. She did a residency in ophthalmology at Wills Eye Hospital in Philadelphia, then 2 fellowships, one in neuro-ophthalmology and orbital surgery at Johns Hopkins Hospital, and the other one in oculoplastic surgery in Boston. She directs one of the AIMO's Ophthalmic Plastic Surgery Fellowship. She has trained very many orbital and oculoplastic surgeons, and she's a member of AIMO's, American Society of Oculoplastic and Reconstructive Surgery, an international member of the European Society, member of ITIDS, and a society officer of North America Society of Orbital Surgeons. She's the editor-in-chief emeritus of Ospite, and I had the pleasure of sharing with her the honor of being in the editorial board of the journal. And I mean, even her research output is an input, I would say, is impressive. So she has almost 150 papers, more are about to come. And she's an avid writer of book chapters and books and review articles. And we had the honor of having Suzanne as one of the very few non-European authors of my book, which will come out at the end of this year. And she wrote together with Benjamin Breyer the chapter on endoscopic orbital surgery. And above all, she's a very good friend of mine and of Diego and of us all. And these are just some of the few pictures that we took together in recent years at American and European meetings. So it's a great honor for me to introduce our keynote speaker, Suzanne Freitag, Teprotumumab in thyroid eye disease. Please, Suzanne.
Thank you for the kind introduction, and Diego, don't cut me off if I go too long. So I'll try to get through this quickly, but maybe with not too many words because I have no Italian. So we got my slides. So I was asked to speak about Teprotumumab in thyroid eye disease. These are my financial disclosures, and of note, I am a consultant and advisor for Horizon Amgen, which produces Teprotumumab. I always start my thyroid eye disease presentations with this slide, just to remind us all that this is a humbling disease. These patients all looked normal a few months ago, and now they have pain and visual disturbance and psychological disturbance. Every patient with thyroid eye disease has a unique constellation of signs and symptoms, and that's what makes treating them very difficult, but we've made progress in the last few years, and I think there's a lot more progress in the pipeline. I like to split signs and symptoms of thyroid eye disease into many different categories. There are more than this. But when we're picking treatments, we need to figure out what's bothering our patients and pick a treatment that addresses what is on these lists. We want to make sure that we don't miss compressive optic neuropathy. I see quite a few patients come into my clinic having seen oculoplastic surgeons with misdiagnoses. These patients require urgent treatment. It occurs in 5 to 10% of patients with thyroid eye disease and can lead to permanent visual loss. The optic nerve in the picture is swollen, but the vast majority of our patients with TEDCON do not have swollen optic nerves. They have inferior visual field defects, and they're inferior because the optic nerve sits high and the annulus is in, and so the superior rectus muscle pushes on the top of the nerve, resulting in these inferior defects most of the time. And you can see that the defects can be quite small and subtle, or as the patients get worse, they can progress and become superior as well as inferior defects. I love Dr. Kazan's mathematical formula of compressive optic neuropathy and thyroid eye disease. His mathematical formula lists the important factors that we should be looking for clinically. If patients have an afferent pupillary defect, that's important, but if it's bilateral, they won't. A summed limitation of abduction is just suggesting how big those muscles probably are. The Humphrey visual field results and color plates. Color plates are so important and so simple to test. There's even an app for the iPhone with color plates. We've talked a lot about the thyroid eye disease management, and for my portion of this, we're going to go straight into the biologics. So the treatment radically changed in the US in January 2020 with the FDA approval of Teprotumumab. It's a fully human monoclonal antibody which inhibits the IGF-1 receptor. It's very wisely approved for the treatment of moderate to severe thyroid eye disease. Very broad FDA indications, which is very helpful. The FDA, Food and Drug Administration, in the US recently acknowledged its use in chronic disease, which is also helpful in our battle with third-party and insurance providers. We've already heard about the mechanism of Teprotumumab. It's an intravenous infusion every 3 weeks for 8 doses. The logistical issues are that it is very expensive and requires insurance authorization, and also it's an infusion, and so we have to locate an infusion center or home infusion nursing service for each patient. The contraindications are pregnancy, breastfeeding, and children because this inhibits growth hormone. We're very careful in patients with ulcerative colitis and Crohn's disease because it can make it worse. And we're careful in diabetics and in people with sensory neural hearing loss because it can also make those diseases worse. And we'll talk about the hearing loss later. We're going to very briefly look at the phase 2 and 3 clinical trials, actually just the phase 3 because they're so similar. These were both published in the New England Journal of Medicine, so big journal, not an ophthalmology journal. This was in 2020. Small numbers of patients, yet remarkably the data has panned out to be comparable to that for hundreds of patients in our more current studies. So there were 41 patients who got drug and 42 that got placebo in the phase 3 trial. The darker lines are the drug patients, the lighter gray lines are the placebo patients. The outcomes, there were significant outcomes in proptosis response, change from baseline in proptosis, diplopia response, which was based on a simple Gorman score, getting the clinical activity score down to 0 or 1, an overall response formula, and a reduction, or an improvement, in the quality of life. The Optic X study came out in 2021, and it's an extension, that's why it's called the X study, of the Optic study, which was phase 3. There were 3 independent groups in Optic X. 1 were the placebo patients from the phase 3, 5 were non-responders from phase 3, and 8 were responders with recurrence. So 8 out of 40 is about 20% of patients got more treatment. This is the placebo patients who then got their drug 6 months after the phase 3 drug patients. You can see their outcomes are basically the same. So waiting that 6 months later in the disease course did not seem to impact the outcomes of Teprotumumab. Of the 5 non-responders who got a second course of Teprotumumab, 2 developed a significant response, 1 had a non-significant response, and 2 patients dropped out of the study. Thank you very much. Of the 8 optic responders that recurred, 62.5% had a significant response with their second treatment. that's the published stuff. But let's take a look at my experience, and I'll share with you some of my published data, but also just some of my patients. So a large percentage of my practice is thyroid eye disease, even before this drug came out, like maybe more than 25%. And it's grown because a lot of people who don't prescribe this drug so often are kind of dumping it to people who do, because the logistics are a little bit complicated. But that's getting easier. It used to be hard to find the infusion centers, but now that's been worked out. And the battle with the insurance companies is something that will go on until the prices of these drugs come down, but it's something that's gotten easier over time as well. I've written about 220 prescriptions for this drug. Some of them are retreatment, probably 10 to 20%, probably closer to 10 to 15%. The age range is broad. The average is a little on the older side, towards 60 years. This is the first biologic that I and most of my peers have managed ourselves. We've relied on rheumatology to prescribe rituximab and other drugs, but this one we manage. And we do baseline testing prior to the first dose, which is quite simple, a serum glucose and hemoglobin A1C. Patients are unlikely to develop glucose problems unless they have pre-existing problems. If they have pre-existing problems, we will need more glucose management therapy, but it is very manageable. We get an audiology baseline test, and recent US FDA recommendation is for audiology evaluation before, during, and after treatment. Just before each infusion, I order a finger stick glucose and a pregnancy test if relevant. The clinical trials looked at patients with active thyroid eye disease defined as a clinical activity score of 4 or more, and patients with compressive optic neuropathy were excluded from the clinical trials. However, our experience and publications show excellent utility in compressive optic neuropathy, which almost always resolves after 1 to 2 doses, and in patients with long-term low CAS thyroid eye disease. So the first case I'd like to present is the most acute patient I have treated with this drug. She was a new onset, recently quit smoking. She had restricted motility with double vision, a CAS of 10, her TEL measurements of 30 and 31, and compressive optic neuropathy in both eyes. So this is about as bad as it gets. This was her appearance and her motility. And we got her emergency dosing of the drug. I can get patients treated within about a week if I push. And so here she is after just 2 treatments. Her TEL measurements were 23 and 26. Her optic neuropathy had resolved by all measures, and her clinical activity score is down to 2. And the 2 points were just for pain and pain with eye movement. There really wasn't any detectable disease activity. So here she is just side by side before and after 2 doses. She went on to complete 8 doses, did very well with the medication, and at over 2 years of follow-up, she has had no relapse whatsoever in her findings. She's had no activity, she's had no proptosis recurrence, so she's done beautifully. Here are her CTs before and after. So we published 48 orbits of 24 patients, quantifying with cross-sectional areas the size of the muscles and then a ratio of the muscles to the orbit. And we found that the extraocular muscle cross-sectional area is significantly reduced following treatment with teprotumumab and nicely correlates with the clinical findings of improvement in motility and diplopia improvement. This is a more routine patient, a 55-year-old, happens to be a physician, recent onset active thyroid eye disease. Her main symptom is a pressure feeling in her orbits. Her lids are swollen, she's actively inflamed, has a lot of tightness and pain, and really minimal proptosis. She waffled about starting the drug. She finally decided to, and is very happy. After 4 doses stated, I look and feel like myself again. And here she is at the end of her 8 treatments. So she's a patient at risk for compressive optic neuropathy because she didn't decompress herself. But fortunately, we got her through this. The next patient was interesting, 72 years old. He was diagnosed for almost a year with allergies because he had this festoon of edema. But when I saw him and his restricted extraocular motility and his lid retraction and other findings and some blood testing, we diagnosed him with thyroid eye disease. He failed IV steroid and 3 doses of rituximab over the course of a year, maybe a little more. And finally 2020 hit, and we were able to get him teprotumumab. And here he is after just a few doses. You can see it's already deflating him in a way that steroid and rituximab did not. Now one could argue that time has gone by as well, but he'd been pretty swollen for a long time and rapidly responded after the drug. So I do believe the drug played a major role in his improvement. So when deciding on treatment, it's important to understand which signs and symptoms our treatments will affect. And so this is this list I showed before of signs and symptoms. And this is my interpretation of what steroid will fix in my hands. So the green light is what I expect to get better on steroid. The yellow is what might get better on steroid. And the red are things I don't expect steroid to fix routinely. And let's look at teprotumumab. So regarding double vision, if people have really full eye movements but some double vision, they tend to get better and resolve. But if they have really restricted eye movements, if the eye is stuck down in an ESO or hypo position, they don't always get all the way better. But we know their muscles get smaller, and hopefully we'll have some strabismus outcome data on these patients soon. It doesn't fix eyelid retraction. We just calculated our data and are submitting it. Patients get 1 millimeter to 1.5 millimeters of eyelid retraction improvement, but many still will need eyelid surgery, and so I counsel patients accordingly. Let's talk for a moment about chronic thyroid eye disease, and I hate to even use the word chronic because in my mind now, chronic means long-term time-wise, but has nothing to do with disease activity. So this is the first long-time disease patient that I treated. I followed her for 4 years in a stable condition like you see on the left. Her tau measurements were still 28, but she did not want decompression because of fear of diplopia. So she had some sutures put in her eyelids to prevent globe subluxation and was leading her life. And then came back to me in 2020 and said, hey, can we talk about this new drug? So here she is after 2 treatments. You can see her eyelid, that rubbery firm tissue is melting away, and her tells are down to 24.5 and 25. This is the longest standing thyroid eye disease that I have treated. This patient is 30 years out. I didn't manage her until quite recently. She's been through a litany of orbital decompression, strabismus surgery, and eyelid surgery. She has what I call end-stage eyelid. There's nothing I can do with these lids. They just won't go where you put them anymore. She didn't have much of a response. And so I think that, let me see if I have my Rundle's curve next. So I know Diego talked about this a bit. This was the classical teaching. This doctor is not an ophthalmologist. He was a surgeon in Australia. What we've learned about Rundle's curve is that patients with the chronic timeline of thyroid eye disease, even years, still respond to teprotumumab. I don't think they respond after 20 or 30 years, but for many years they seem to respond. And patients with low disease activity, low CAS, also respond. So I think this static phase of Rundle's curve, I think of now as subclinical disease. If they're responding to these drugs, there's still disease activity, but we're just not detecting it clinically. Let's talk about a type 1 fat hypertrophy variant. So these are often the young patients with proptosis and lid retraction who really never get double vision. And as Don Kikawa and Bobby Corner are talking about now, a high fat to muscle ratio if you're looking at your CT and MRI images. So this is a classic case of, this is my patient. She's 22, she's euthyroid, she's a non-smoker, smart girl, graduate student. She's had non-progressive disease with normal afferent function, her tells of 26, severe lid retraction, 3 millimeters of lag with keratopathy, which is very bothersome to her, even though she's young, and her globes sublux often. And this is her CT image which is just a classic fat hypertrophy with small muscles. So her goals were to reduce proptosis and reduce lid retraction. She declined an orbital decompression. She reads all day, and she didn't want to get double vision. There's really no indication for steroid or anti-inflammatory medications because she's really never been active. So eventually 2020 rolled around for her. She got Teprotumumab. She completed 8 doses, tolerated it very well. And this was her outcome. So you can see that some of the spottiness of her orbital fat improved on CT imaging. Her muscles may be just a little bit smaller, but clinically she's very similar. She only got 2 millimeters of proptosis reduction, which is less than 10% for her. So she still had problems. 1 year later, she had 2 millimeters of proptosis regression. Again, not highly significant, but just not making any progress. She ultimately underwent orbital decompression followed by eyelid surgery after she finished her graduate studies. So there are patients that this drug doesn't fix, and we still need to do orbital decompressions and other surgeries, but I think our pathway to them has changed. Leg and foot dermopathy is a horrible problem that I wasn't familiar with until recently. I'm told by my endocrine colleagues, you rarely ever see this unless the patient has severe thyroid eye disease as well. So these patients can get Teprotumumab, usually based on their eye findings. This patient had undergone radiation therapy for years. She couldn't wear her own shoes and she was crippled getting around. I have another patient who had skin grafting and radiation therapy to her legs. This is a really awful, awful thing. And here she is after treatment, and this is pretty much back to baseline for her. She's a person who has wide feet at baseline. You can see the inflammation is gone and she's wearing her own shoes. Let's talk about adverse reactions very briefly. The vast majority of patients who start the drug finish the drug. And some of them have these findings. My data, which is this, is extremely similar to the 40 patients in the phase 3 clinical trial. So those 40 patients, in my opinion, have stood the test of time as far as the percentages of these findings. About half of patients have muscle spasms. Most of the time it's not terribly bothersome. Some patients have fatigue and a little bit of nausea after their first dose or 2. Again, tends to fade over time. A few people early on were complaining of some change in taste. Haven't had much of that recently, actually. Amenorrhea is quite common in young women, but all of these problems reverse after about 6 months. About a third of patients have ear or hearing changes. That's different from different from hearing loss. A lot of people have popping, buzzing, clogging, which is not very bothersome, and they don't really bring it up unless you really grill them if they're having it. A low percentage of people, almost all of whom have sensorineural hearing loss at baseline, can have progression of their hearing loss. So that's why it's important to screen these patients and to probably eliminate some of them with serious hearing loss from being candidates for the drug. It's a complex conversation because many patients who suffer hearing loss want to continue the drug because they care more about their eyes than their ears. So we've had some interesting conversations. But I feel quite comfortable dealing with the hearing loss because if you screen patients and know where they stand before treatment, it's a manageable situation. Let's talk about recurrences. So you give a drug long enough to patients, you're going to see some recurrences of disease once the drug is stopped. So this is my first patient with a recurrence. She's 65, she's euthyroid, she's a non-smoker. Her thyroid eye disease onset was 10 years after her Graves' onset. She had optic neuropathy, double vision, and her tells of 24 and 27. These were her scans prior to any treatment with Teprotumumab. She was one of the early patients I treated. She did very well even after 1 dose. Her double vision and optic neuropathy resolved. And here she is pre-treatment and after 8 treatments. So her TELs went to 22 and 22 and a half. So she wanted her eyelids fixed, her upper lids. So I used to wait a long time, a year or more after the acute phase before I would do upper eyelid surgery. So we waited. And 7 months after completing teprotumumab, I did upper lid internal recessions and upper lid blepharoplasties. Here she is 1 month later. And my outcomes don't usually look like this. She had a lot of recurrence of her upper lid retraction on one side and some chronic edema on the other side. At 2 months post-op, she said, you know, I think my eyes are getting worse. I'm getting a little double vision, and it progressed over a few months. And so she was retreated. And here she is after 1 dose and 3 doses, and you can see that things are quieting down again. So I had to redo some of her eyelid surgery, but she responded very nicely to a second course of teprotumumab. Retreatment, I think if you talk to different people who prescribe a lot of this medication, you're going to get a range of about 10 to 20% of patients are getting retreated. Now, the CAS often means low in these patients, and the most common patient concerns leading to retreatment are double vision, because it's a horrible problem, pain and pressure, discomfort. Patients want more if they're in pain. Some patients get eyelid edema and puffiness. It's not always red and inflamed. Sometimes it's just more edema. And some get proptosis recurrence. So here are some of my patients that I've retreated. This patient started off at 27 and 25 with some enlargement of muscles and double vision. The next from the left is after 8 teprotumumab. She got down to 22 and a half and 22, and her diplopia quickly had resolved. About 16 months later, she progressed again. Her TELs were increasing. You can see there's increasing fullness in her perioral fat and some swelling. Her double vision didn't come back, but she had enough discomfort that she really wanted to be retreated. And here she is after 6 doses. And again, getting a very similar outcome, or maybe better outcome than the first. I think in the second slide, after 8 of 8 treatments, she still has some eyelid edema as well as steatoblepharon, and I feel like in the final, her edema is finally all going away, and what we're seeing is just the steatoblepharon that's left. Here's a different patient. This is a high demand patient. She's a dentist, and her eyes get very dried out all day while she's working, and she gets pain behind her eyes. So she started off at 20 and 21. She got a little proptosis reduction, a little bit of eyelid retraction improvement, but her eyes were not as dry as they were. And I can't tout that all to a massive proptosis reduction. I have some male patients who also have told me, yeah, I'm not carrying my eye drop bottle anymore just because my eyes are just less dry than they used to be. So 16 months later, proptosis is a little worse. The eye dryness and pain is back, and that was really the driving force for retreatment. And her second outcome is as good or even less inflamed than her first outcome. Here's another patient, her TELs of 21 and 23 with double vision. She got 8 treatments, a lot of proptosis reduction percentage-wise, down to 16. 6 months later, and 2 months after upper lid internal recessions, she's has a lot going on again. She's not that proptotic, but her double vision's getting back, and that's the real driving force for her wanting to be retreated. So these are the common stories that the patients are retreating. So they're not all red hot and inflamed, but they just have some creeping issues that are bothering them. And what this is really telling me is there are a subset of patients that just need longer treatment. I don't think of this as a drug failure. We see it from the Optic X. Not all thyroid eye disease runs the same course. And whether I'm setting these people off with surgery or it's the natural course of their disease, some people just need more treatment than others. This is an unusual patient who got quite inflamed. She's had thyroid eye disease for years. She also has uveitis with no light perception vision in her left eye and visual field loss in the right from uveitic glaucoma. So what vision she has is very precious. So she received teprotumumab, did great, a lot of proptosis reduction, but also a lot of quieting of her inflammatory eyelid and orbit disease. She came back 14 months later, very inflamed. Her uveitis had been quiet, but she had gotten one of the very unusual, highly inflamed recurrences. And here she is after 8 more, looking as quiet as ever. So hopefully we can keep her there. We did a study recently looking at proptosis regression after teprotumumab treatment. And framing this, that 2 millimeters has been the cutoff for significant proptosis reduction. The purpose of this study was to not look at this 2 millimeter bar, but to look at all thyroid eye disease proptosis reduction, be it 0.5 millimeter, 1 millimeter, because a lot of patients get a 0.5 millimeter or 1 millimeter of proptosis recurrence, and it's insignificant clinically. So we wanted to look at everything. So it was retrospective, done at my hospital on our patients completing 8 doses. The mean age, again, 56 years. So our patient cohort was 119 patients, 208 eyes, and 87% of them had initial proptosis improvement after treatment. A lot of women, mostly Caucasian patients, mostly non-smokers. My smoking population of my patients is 5% or less. Mostly graves, mostly active disease, in this case meaning a clinical activity score of 4 or more, and a few with optic neuropathy. So we looked at 2 time frames in our study. One was most recent follow-up versus immediately after treatment. So 78 patients, 102 eyes of 59 patients had regression. That's 0.5 millimeter or more. That's any regression. And you can see that 73% had this in both eyes and 27% had it in one eye. If you look at the numbers, the average regression was 2.4 millimeters. And this is a 12.8% reduction. You need to start thinking percentages, not raw numbers for these, because people start at all different places. About 10% of patients were stable, and then about 38% of the eyes had a regression of more than 2 millimeters. And the average of this was 3.4 millimeters. So looking at Ray Douglas's paper, just as a comparison, they had 25.5% of patients with initial proptosis improvement who had a 2 millimeter or more flare. So comparing apples to apples. The time to proptosis regression, I think, is a little artificial because there are so many more patients in the shorter time categories, right? That's just sort of the way this plays out. But the majority were within 6 months, 40% at 6 to 12, and fewer patients are farther out in the time course. So then we looked at proptosis regression compared with pre-treatment. And so 25% of eyes had a little more proptosis at most recent follow-up than before, but this was 1.5 millimeters. Again, in the big picture, 7% or 1.5 millimeters is not a significant amount. 63% of patients maintained their improvement, and the average reduction was 3.13 millimeters. So if we frame it this way, 60% maintained a reduction of greater than 2 millimeters, and 20% regressed by 2 millimeters. In this patient population, the clinical activity score pre-treatment was 5, post-treatment was 0.8. This was significant. And of the patients who had proptosis regression, their CAS remained low, 1.74. So as I was shown with my own patient photos, these are not red hot recurrences. This is a little bit of creeping of proptosis in a lot of these patients. So 2/3 of patients have some regression. Most are less than 2 millimeters, and most maintain a CAS of less than 2. Follow-up is important, and I think that this highlights that we need to follow our patients. Some will need treatment beyond the initial dose, But the compelling reasons for treatment are not proptosis recurrence. It's double vision, pain, severe eyelid edema. It's sort of cost quantification, but another $400,000 expenditure is not justified for 2 millimeters of isolated proptosis recurrence. So in my experience, when patients are retreated, I tell them to expect the same outcome as their first treatment. And I showed you that with my series of patients. And this underscores the importance of being able to tailor the treatment to maintain these great outcomes that we're getting. Some people just need more drug. And currently we don't have a lot of control over this. Third-party payers buy the drug, and then they dose it to the patient, and they get reimbursed when the drug goes into the patient. So they're highly motivated to treat every 3 weeks as per protocol, whereas patients and I would like to spread it out much longer. So in conclusion, this drug is a powerful addition to the armamentarium of thyroid eye disease treatments. It's effective in moderate and severe thyroid eye disease, and few patients are complete non-responders. It can be rapidly effective in acute thyroid eye disease and effective in quickly reversing compressive optic neuropathy, and can be very effective in chronic disease years after the acute phase. Radiographically, it's been shown to reduce extraocular muscle size and proptosis. It clinically reduces proptosis and periorbital and eyelid fat. We used to tell patients that they would never look the same as they did before their thyroid eye disease. And for many patients, this is not true anymore. And this is just the beginning. I think there are a lot of similar and dissimilar biologics in the pipeline, which will continue to help our patients radically. Thank you.
Thank you. Thank you, Suzanne, for the absolutely outstanding presentation. It's impressive also that honestly I missed the results of the recent study on optic compressive neuropathy, which seems very encouraging to use this medication. The problem is, I was wondering why you were presenting. Currently there is a kind, especially in Europe here, kind of guidelines to treat compressive optic neuropathy, which kinds of, make mandatory to treat those patients first with high-dose steroids and then eventually, if they don't respond very well, with decompression. So I was wondering how, if in the United States you are, North America in general, you can use as first-line treatment nowadays Tepro for compressive optic neuropathy?
Absolutely. I don't even start steroid in most of the patients because I can get the drug on an emergency basis by working with Horizon Amgen, usually within 7 days. They'll get us 2 doses, which is enough to fix any compressive optic neuropathy that I have ever treated with Teprotumumab. Most of my patients aren't so far gone that I have to give steroid for that first week. Most of them I can just sit on for 6 days or so and get the drug to them. And it works very rapidly.
Penso che la domanda e la risposta è chiara a tutti. Ho chiesto se era possibile, se negli Stati Uniti era possibile trattarlo l'ortitopatia compressiva come trattamento di prima scelta con Teprotumumab. La mia risposta di sì, è possibile averlo proprio come emergency base. E adesso la mia domanda sarà: se non funziona, che cosa fare? So, Suzanne, the next question is, but if the patient doesn't respond to the first treatment with the Tepro in compressive optic neuropathy again, what do you do next?
I've never had that happen.
Okay.
I would be shocked to have someone who didn't respond. It's those red hot ones that call you back the next day and say, oh my God, I'm totally better. You know who the fast responders are going to be. They're those CAS-10s that their disease just started. And so often the compressive optic neuropathy patients fall in that category. If I had some long-term chronic compressive optic neuropathy, maybe it would be different, but I would go back to my usual, which would be, depending on how bad they are, try to either just cure them with steroid or tie them over with steroid and quickly decompress them.
Thank you. Please.
A very quick question. So the first is, because most people are very worried about side effects of Tepro. So my first question is, what does it happen to the hearing problems when you discontinue or you end the therapy? So this is the first question. And then what happens if you have recurrence after retreatment? Le due domande rapidamente, molti sono preoccupati degli effetti collaterali di questa nuova terapia, quindi cosa succede una volta che hai problemi uditivi una volta che la terapia si smette, e poi la seconda è se hanno avuto un ritorno della malattia dopo il secondo trattamento.
So regarding the hearing, we know there are IGF-1 receptors in the ear. So it makes some rational sense that the drug affects the ear in hearing. That exact mechanism is not completely understood. There are now a number of ENT doctors who are otologists who are starting to team up with some of us as individuals and with Horizon Amgen to try to understand this better. Some big pools of data have been crunched, and some prospective studies are being proposed. It's not deafness. It's a decrease in hearing. The consensus that I'm aware of is it happens after 3 or 4 doses. And in my patients, it tends to not be progressive. And I know this because patients are junkies and they want to stay on the drug. Just give me one more dose, doc. I had one patient who was an audiologist who tested herself after every dose. And she said, I'm sure it's the same, it's not getting worse. Give me one more dose, I'll test myself. If it's still the same, I'm going to finish. And we haven't seen a lot of progression after the dip, but I think other people have had different experiences, but that seems to be a consensus among many of us. I have not had any patients, well, I haven't had a lot of people lose hearing because I've been very careful since the beginning about screening people. But there is some talk now that maybe up to 50% of people are getting some improvement over time after having some hearing loss. But this has to be parsed out carefully from patients who just have the clogging and buzzing and popping, like they just got off an airplane or have water in their ear. That's a very different phenomenon, and that goes away. And it doesn't seem to bother most people either. So if you ask people carefully, you can parse it out. Your second question, Francesco, was about recurrence after retreatment. So I've yet to prescribe a 3rd dose. I have one patient who would like a 3rd dose, but she's not that bad off. And my dentist wants to live on the drug forever because she just feels so good on it. But I have yet to have a significant recurrence after 2 courses of drug.
Thank you. Rapidamente avete capito la risposta ai pazienti, soprattutto per i side effect. Ci tenevo a dire che ci è successo anche nella nostra esperienza a Napoli, che usiamo il Tepro, i pazienti, nonostante hanno un decremento, la malattia è così frustrante per loro che addirittura talvolta simulano che no, va bene, l'orecchio va bene, perché vogliono altre dosi, continuare e non uscire dal trans, perché il miglioramento della loro qualità della vita è veramente importante. Prego, Gustavo.
And do you think that maintaining those after the therapy can prevent a regression?
Well, no one really has that formal data.
Mm-hmm.
Some patients try to stretch out their dosing by calling in sick for their infusion and putting it off. And there are probably some individual cases that people have collected. There's really nothing published, but we've given some people 2 courses, and we have not yet, since 2020, or at least I have not yet, in 220 patients, had someone come back needing more. I'm sure there will be, but we could have prevented those recurrences or caught them much earlier if we had an easier way to get drug to patient, some pills at home or a sub-Q that they could get a supply of them, and we could say, let's do this as maintenance every 6 weeks or something. And once we have control of the dosing, if it's not done by a third party at an infusion center, I think we're going to be able to eliminate a lot of this, what we're calling recurrence or ongoing disease activity flares.
Thank you.
Altre domande? Siamo alla fine e quindi ringraziamo Suzanne, grazie for your beautiful presentation e veramente quindi è stato un piacere avere, it was an honor, a great, I mean also I think that was very important, relevant the information that you gave to all the audience, and we deeply thank you again, Suzanne, for coming so far to share great experience. I think one of the largest experience ever using this medication. Thank you again.
Thank you.